Time now for this week's Health Matters. Paul Critz with you, along with physician assistant Lynn Szabo. And Lynn, we're jumping back into the COVID pool this week, but it's the deep end of the COVID pool, isn't it, here?
Totally. And I think the COVID pool is like being poured over us, actually.
Is that what that's
yeah,
a better?
That's kind of what happened. So long COVID, I'm seeing a lot of it in the clinic.
Now, long COVID, I mean, it's something that I read about and see, mentioned. And then there was, as I was telling you off mic before we started, there's this a YouTuber, she's called the Physics Girl, and a scientist, has a terrific YouTube channel. And for a lot of months, I hadn't seen anything for a while. And there was an update came out a while back earlier this year from one of her production assistants. She's got long COVID and is in a cocoon, in a bed, in a dark room for months. And her husband is blending all of her food. And a good day, she can sit up and chew. And I'm like, my God, this is horrible.
It's horrible.
That's the first example of it that I've seen.
It's really horrible. And I'm not seeing anything that severe in clinic, but I did sit in on a Maven Zoom lecture about long COVID, and all they could say was, "Don't get it. Don't get it. Try and keep from getting it. Immunize. Take Paxlovid. Don't get it."
Wow. Okay. Well, what do we know?
So, long COVID's defined as symptoms that persist for more than 4 weeks after an initial infection, and it really doesn't matter about the severity of the infection. So, if somebody has an asymptomatic COVID infection, and then all of a sudden has some of these symptoms, they kind of are never going to see it coming.
Right, right.
Yeah, it's kind of a stealth operator. And get this, 10 to 30% of people with COVID go on to having long COVID.
Wow.
I think it's probably actually a little bit over amplified because those are people that have known COVID.
Oh, okay. So the people that who don't know, they're not in those numbers.
But 10 to 30%'s a lot.
And I want to restate again the example that I just said with this YouTuber. That's the exception, right? As far as the severity of long COVID.
In what I've seen, but that's, I have a skewed sample size, right? I see people that are well enough to come into clinic.
Yeah, good point. Okay. Okay.
And labs and imaging are pretty much normal. I mean, there are some baseline labs that you should get if anybody has these complaints. But they all pretty much come back normal.
Well, what sort of complaints are we talking about? I know we might be jumping out of.
Yeah, that's fine. So profound fatigue, a little bit like, remember the old chronic fatigue immunodeficiency syndrome that was called the yuppie flu?
Right.
So profound fatigue, like getting up to go to the bathroom is more than somebody can manage in a day. Weakness, lightheadedness. Pulmonary, like vague pulmonary function issues, like shortness of breath or dyspnea on exertion. Cough, chest wall pain is one that I'm seeing a lot of. That's kind of a mystery. Cardiovascular things like palpitations or syncope, something called POTS syndrome, and that's a blood pressure drop when you go from lying to sitting to standing,
right? Or
like most normal people would probably go from lying to standing, and all of a sudden their blood pressure cuts out and they faint or come close to fainting. Okay, and neurologic things like brain fog. That's really what people complain about. The number one, they can't smell, they can't taste, or dysgeusia, my favorite medical word of the week, which is a foul taste in the mouth for no apparent reason.
How do you pronounce that? Dysgeusia?
Yeah, that's what I said.
Okay.
Dysgeusia.
And you translated both of these terms, or at least the one, anosmia? Is that you can't smell anything?
Not being able to smell.
Okay. All right. I was just called that smell blind.
Yeah.
Okay.
Yeah.
Anosmia. That's great. Those two good. I'm going to write those down.
Yeah. People are going to think you're like brilliant. So who gets
you, sir?
this?
Give me a dysgeusia. No, that's so. I'm sorry. That's just fun. It's fun learning new words. So yes,
okay.
Who's at risk? Is there a population
it's
slice?
All the people that kind of get ignored by medicine, and a lot of them have a lot in common with Del Norte. So white race, generally poor baseline health. Okay. So people maybe that when you see on the schedule, you go, oh my God, we're going to have to go through 25 different complaints, and most of them are hard to understand, so they kind of get shuffled off to the side.
Oh, wow.
Older people, female people, overweight individuals, people with asthma, which remember in the beginning of this, we thought people with asthma did fairly well through COVID.
Right.
So they're at risk for long COVID. And people who have multiple bouts of COVID, that's what I'm seeing.
So white, out of poor health, overweight,
Right.
asthma, multiple bouts of COVID. Yeah. How much long COVID do you see in Del Norte? Because this is a
see
breakdown
a lot of it.
Yeah.
I'm seeing a lot of it, and it's hard because you can't really go in the room and just go, oh, yeah, you got long COVID. You have to keep an open mind because a lot of these symptoms are really vague, and they could be other things. Like older overweight women get atrial fibrillation, and they might have a result of chest wall pain and some shortness of breath with that. So, and anxiety about it. So, it could be a lot of things. I think the provider is obligated to do some testing, but mostly what I'm getting back in my workups, just the general wide net, is negative. Everything looks okay.
Everything meaning what?
Meaning all the labs and
Right.
imaging and
That-
EKGs and all that stuff.
This
looks
was
okay.
my next question. Then, what do you do as a healthcare provider? How do you hone in on it being long COVID if the labs are all presenting
It's
okay?
almost a diagnosis of exclusion.
Right,
So I
right.
should explain what that is. So
No, I
in
know.
medicine, if you make sure it's not all these other things, then whatever's left over is what they must have, right? But that's like not satisfying.
No, that's akin to proving a negative. That's a difficult
Right.
thing to do. Yeah.
Right. And I think sometimes people don't feel particularly heard. Especially now that I've seen enough people, I kind of feel like I can spot it, and I try not to spot it. You
That
know what I
makes
mean?
sense, sure.
Because you really have to, and I'll tell people, look, I think it's like a possibility, but let's make sure it's none of these other things. Because people have to be evaluated correctly, and they have to feel heard. And they don't, especially if it's somebody who opted not to get immunization, opted not to take Paxlovid, it could be really easy for them to hear, well, what do you expect?
Right.
So, and I try not to go there. It's not fair. It's not therapeutic. It's worthless. But actually, something that does help it is immunization. So about 50% of people get better with immunization.
Immunization after long COVID?
For
Wow.
COVID, even if it's quote unquote an extra immunization.
Huh.
So they think what happens is they have a low level chronic viremia. So what that means is just like smoldering coals of the virus. So they're still reproducing and still attacking the body, but it's kind of like under the radar.
Right.
So, and there's no real good test to pick it up.
So, and I suppose there's no understanding about how, if it is in fact this hypothesis that you've got like the embers of COVID laying around, that how if it never burgeons up to become like full blown COVID with the full viral load and all of that, if it stays this low key under the radar thing, how that translates into being expressed with long COVID symptoms.
Right. So they think there's a low level immune war. That's the same thing they thought with chronic fatigue syndrome.
Was it?
back.
Okay.
Yeah, there's this low level kind of like struggle between the immune system and the offending agent.
Right.
So-
Not enough to make you sick, but over time, a really debilitating like stress.
Right. It's like it takes your body's attention away from living and just keeps everybody miserable.
Wow.
It's really sad.
Yeah.
And it bugs people. So I'm going to jump down to the brain fog because this is a super big problem. People you can see it on their faces. They're trying hard to follow what you're saying, but they don't quite get it. It's kind of a little bit lights on, nobody home, but they're really trying. Okay. So what I believe it needs is some form of cognitive testing and a neuro referral. So the local neurologist has seen a couple of my patients with COVID and was super helpful, but I don't think he's doing that, air quotes, doing that anymore. I think he's saying he's not treating or not evaluating long COVID anymore.
How could
I know. How do you... Because there's nothing to say. There's nothing.
Well, help
there's
me
nothing to do. It's super unsatisfying. medicine.
Sure, I get that, but I'm just trying to logically understand, and maybe I'm just the way.
And I may have it wrong. Okay.
I'm just saying, how can you say I don't want to? Like, how can you go and say I don't want to do this thing that I won't know if it's that until I evaluate it?
And he
do
actually
it?
was super helpful with a couple of patients
Really?
before I got that message back. Maybe I have an inaccurate message open to being corrected. So cognitive testing is super important here. And I think it's important in the diagnosis, but there is nobody in town. The behavioral health people say cognitive testing is done by the neurologist. The neurologist says it's done by behavioral health. Both of them, every once in a while, get frustrated and look at the primary care provider. And then, do you really want to have cognitive testing done? Because what if it really shows that you're not competent to make your own financial decisions? Do you even want to ask that question? I mean, this is a whole can of worms.
Sure.
So yeah. I've sent people down to specialized long COVID clinics in the Bay Area at UCSF and Stanford, and pretty much they don't do it either. So I don't know how somebody gets monitored, gets diagnosed, gets better. How do we put a number on the brain fog? They just one day decide they're better?
Do they just leave it as like self-reporting, basically, as a subjective state that we really can't quantify or qualify? Huh.
We can, but we aren't.
So when you talk about cognitive testing, is that like the test they gave Trump?
Oh,
where,
yeah.
This is a hippopotamus,
his test
this
was
isn't you?
like the kindergarten version.
But that's the kind of thing we're talking. Yeah. Okay.
So there are recommend for the brain fog things that help. Aerobic exercise 2 or 3 times a week. This is all going to sound familiar.
Yep.
Train your brain with notes and break down tasks into smaller steps.
What's the training your brain with notes?
So those are like little Post-it notes.
Oh, okay. I thought you were just at the end of the day, you sit down and you say, brain, I have some notes.
No. It's like, maybe you have an appointment at 1:00. You slam up Post-it notes somewhere where you can see it.
It's
by your car keys
the string
something.
around your finger kind of thing. Yeah.
So breaking down tasks into smaller steps. Okay. So not getting so overwhelmed. So the whole thing about maybe making dinner, maybe you're going to make the main course first and then take a break, and then you're going to make, that's not super impossible to do. Slow things
Not if you like cold food.
Yeah. That's why they made microwaves.
That's true.
So word association. So I kind of do this, not completely, but I have chickens. It's important to me that my chickens are closed at the end of the night, but I'm sleepy at the end of the night and tired, and like my brain juice is gone. So that my chickens are shut in. I just don't close my shades until my chickens are shut in.
Oh,
so
that's
if
a good
the
thing
shades
to
are
know.
open, that must mean something about the chickens. That's not really word association, but that's similar.
That's akin to tying a string around your finger. Yeah.
Right.
Yeah.
And self-talk. So talk to yourself about what you're doing so you don't lose track. I'm walking into the living room because I'm looking for my car keys because I'm going to go to the grocery store.
Right.
Just kind of keep that dialogue going.
And that makes, so many of these things with like brain fog and any sort of subjective states like this, they lead to isolation.
Right.
Because you get wrapped up inside your own head.
It's just too frustrating to try and keep up or trying to explain yourself constantly,
To whom?
Well, to people around you.
Oh, I thought you were still doing the self-talk thing. So you're going, why did I walk? When you walk in a room and you go, why did I walk in this room?
Well, if you were doing self-talk, you would catch yourself up.
Exactly.
And then what we've talked about before, good sleep hygiene, because that's kind of the brain dishwasher, and that cleans all the gunk out and
Everything
makes you
is
work a little bit better. Actually, part of it on the microvasculatures, they think there's microclots that aren't pick-upable on scans and things. And these clots kind of interfere with normal flow of neurotransmitters and stuff. So sleep makes sense here.
Why? How does that address the microclots?
Well, remember we talked about sleep hygiene, and I think we talked a little bit about how it relates to dementia, where every night when you get into the good restorative parts of sleep, what's happening is your brain is kind of like cleaning through.
Sure,
Like there's this actual lymph, it's not a lymph flow, but a similar flow of fluids that's designed to like clean all those nooks and crannies.
Really? That's so cool.
Yeah, we talked about that.
I don't
It was
remember
cool.
that. No.
Well, maybe your sleep hygiene is lacking.
That's entirely possible because I'm a big fan of good sleep nowadays,
Right.
and that's a relatively new thing in my life. Same with hydration, the next
Yeah.
little bullet point on your list.
Hydration, yeah, something super easy you could do. But I mean, when you go to a doctor's office and you're saying, look, I can't think anymore, and they say you should hydrate more. I mean, that sounds lame, but that's what we got. Okay.
Yeah. Well, I mean, well, that's how important that is.
Yeah. So decreasing screen time.
That also is important.
Yeah.
The color of the light, how close it is to you trying to sleep, all of that. Yeah,
Right.
I try to spend the last couple of hours of consciousness away from all of this.
Yeah.
Yeah.
It's hard for me to do, actually.
Really?
Yeah. So, and counseling sometimes, because I would imagine if your brain all of a sudden doesn't work very well, you'd have some depression.
I got some
about it.
questions. Yeah.
But-
I want to know more about anosmia, anosmia.
So this I actually have seen a lot of, and I was like, yeah, who cares really? But it'll come back, no big deal. But actually, this is a problem because it's a safety issue, and because you can't smell things like. That pan that's in the kitchen that's on fire.
Yeah. The gas fumes.
Yeah, stuff like that.
Yeah, right.
So
smoke.
This is kind of a big deal. So there is a way to post-viral smell retraining. Coronaviruses have been known for causing anosmia for a long time.
My eldest, after her bout with COVID, decreased smell capabilities and taste for about 6 weeks, I want to say, afterwards before it finally cleared
I've
up.
seen people have had it a couple of years.
Ooh, wow.
So, but there is a way to retrain your olfactory senses. So to do this, you start with 4 memorable scents.
Oh, neat.
So smell retraining, smells are oftentimes really tied to emotional memories. And so what they're trying to do is to tie that smell again to an emotional memory. So they suggest the 4 scents you pick are rose, lemon, clove, and eucalyptus.
So very different.
Very
scents.
distinctive,
Wow.
very common. Everybody's had experience.
I may
with
do
it.
this just for fun.
I know. This is cool, but it involves some buy-in for a while. So you could use an essential oil. I would go down maybe to a health food store and buy an essential oil. So smell each scent for 10 to 20 seconds once or twice a day. Okay. So that means you probably have to work on rose for a while and then lemon for a while. And then, and try and remember each smell in like a context of a specific memory. Like roses in my mother's, garden.
Right.
Okay.
Okay.
Or cloves on Thanksgiving, or eucalyptus on that hike. You guys get it. And then in between, so you're doing, let's see, so you pick lemon, you smell lemon for like 20 or 30 seconds. You try and you're thinking about whatever associated memory you have. And then you move on to the next smell. You have to take a few breaths as kind
You got
of
to
a
cleanse your
smell
palate. Yeah.
palate cleanser. And then you move on to the next smell. But they're recommending that this has to be done for 12 weeks.
Wow.
So this ties in appropriate memories to the scent and kind of reminds your olfactory, it's probably your first cranial nerve, the olfactory sense that this is a thing.
Yeah, right.
Turn back on, this is a thing. And cements it in there. Now, I don't know if that means the rest of it comes back or if you're stuck for the rest of your life.
Or all
with
you
these
smell
4.
is right. Yeah.
Yeah. Or do you move on to, maybe 4 other trigger smells?
I don't know. I mean, it seems like what you're doing is you're waking up the neural pathways again, right?
Right.
And once you
maybe
get those
even
going,
reestablishing new neural pathways.
Interesting.
Yeah.
Okay.
They also suggested intranasal steroids like over-the-counter Flonase.
Oh, okay.
Note on over-the-counter.
Right.
It's expensive, but Flonase is something that's helpful. And then update your like gas detectors in your house or your smoke detectors, because know that you might not be the person who figures out the kitchen's on fire first. And then they suggest updating your COVID vaccination as a treatment for anosmia. I'm saying it wrong. Anosmia.
Wow.
Nausea.
Again,
Yeah.
that's interesting that it's, well, I guess maybe that isn't. I mean, if we're talking about, so I can understand how the vaccine, like updating your vaccination, if you're experiencing long COVID, if long COVID is, a matter of these kind of, sort of terrorist cell COVID,
Right.
bits of COVID left behind.
I think it's more than one thing, actually.
Really? Okay,
Yeah.
I want to come back to that, but I'm at a loss as to how updating your vaccination might help with a condition like anosmia, if it's. I guess if we're just in the context of long COVID, then we're talking about the fact that your body has not been able to get rid of the COVID.
Right. If the virus. Is kind of smoldering at a low level on your first cranial nerve, which is the nerve responsible for
right,
smell,
right.
and then your immune system can seek it out and attack it
Yeah.
as a renewed assault.
Yeah.
So,
yeah.
but I also think, like I said, the microclots are a thing. I think there's a generalized inflammatory response.
Mm-hmm.
This is like a battlefield after the battle's over,
Good point. Yeah.
and you have to clean up on multiple fronts.
Right. It's called mopping up operations. Right. Yeah.
Totally.
Yeah.
And I also think that people that they're not thinking their best because of the brain fog, but I think they feel badly, not necessarily because they've done anything wrong. It's just they feel sought out and punished.
What do you mean?
Because there's other people that go through COVID and do fine.
Oh. So you're
I
taking
think-
it personal if you get long COVID, kind of? Yeah. Yeah.
Like a body failure, and I think they have some depression and anxiety around that.
Oh, wow.
Yeah.
Yeah. Guilt, maybe? I don't know. I guess it depends.
I don't know. Guilt might be a big deal because you don't have really any control over it. So I don't know why anybody would feel guilty. But it's like, really? Me?
Yeah.
Why do I have to go through this? So,
Because it's your fault.
no.
That's where the guilt comes from, see?
Yeah.
Maybe you
but
don't have that dynamic inbred in
I don't
your
know. I'm
in
kind
your
of
head.
Vulcan.
Yeah, that's it. Right. And
Yeah.
you should be.
Yeah. So,
But damn it, Spock.
yeah. I'm a doctor, Jim. I'm not a doctor. I'm not a
I'm
doctor.
a physician assistant.
Yeah. But I think there's going to be more understood, and I think the YouTuber that you're referencing is a bright, intelligent woman, and will find her way out of this. But certainly, from those people's struggles are going to come new insights that will help other people too.
Wow.
But what a drag,
Yeah. Because I just hate the feeling of fatigue in general. I just don't like it. And I know that's a stupid thing to say. Who does? I know people who are I don't know, perhaps people I'm married to who are perfectly fine sleeping until noon and beyond. And if given her druthers, would spend all day just down and relaxed and I can't do that. I'm like up, like this morning, I'm up at 8:30. I'm making coffee. I'm like, okay. And I try not to be like, you're less of a, like you're not as good a person because you're sleeping in. I really don't want to do that. I am at 2 with fatigue. I just don't like slow fatigue. That would be like hell to have to like stay in bed all the time with an eye mask on. And
that would be.
I can't imagine doing that.
And drinking pureed food. And,
Yeah.
I mean, and think also about their marriage.
He's just a caretaker is all he is now, and she's just an invalid.
Yeah.
And there's nothing else going on.
It's
Yeah.
sad on so many levels.
So yeah, and particularly in her context, and I'm sorry, I don't remember her name. She's the physics girl on YouTube. If you want to go check out her channel, she's incredibly like knowledgeable and a straight up physician. Physicist. She's a scientist and does all these crazy things and has a production team and there's money in this. It's not just somebody in a garage doing a YouTube stuff. It's really, really interesting, good videos and nothing just for all of this year. Where are we? June? I think it's been all of this year, just almost like in a coma, just with the shades drawn. And it's so sad to see.
Yeah.
And I don't mean to cast aspersions on my wife for sleeping. I didn't mean to do that. Lisa, if you're listening, it's okay that you're listening in bed still. It's all right. It's a Sunday. But yeah, that's man. Just another one of the many things that we don't see. Is there anything in the world of illness? Is there any other illness syndrome that does anything like this?
Well, the old yuppie flu, chronic fatigue.
Did we ever develop any
deficiency.
sort of real understanding of what that was?
Not on the practical exam room level that I'm aware of. I think there's some understanding in science of it, but I don't think there's anything that's translated to anything like practical,
Right.
like what you could do about it.
Do you think that the experience with COVID and long COVID might shine a retro light on chronic fatigue
Right,
syndrome?
because I think what we're looking at is not really necessarily just long COVID. I think we're looking at post-viral syndromes. And yeah, I think understanding could come from that. And so like some pivotal understanding could happen that would help all people with all the different
Right.
manifestations of
Right.
a chronic post-viral.
Like this is how a
fatigue
virus, any virus, can affect you coming through your system like this.
Right.
Wow.
And then I think we'd be able to have more refined markers for who would be more at risk.
Was there ever any understanding about whether or not chronic fatigue was viral?
It's thought to be post-viral. They thought it might have something to do with Epstein-Barr virus, but that's not really agreed on anymore. And I think what we were looking at is the syndrome post-viral, many different kinds of viruses.
Right. Okay.
So,
I didn't know if that's what we had arrived at now, or if that was what
I
we
think
could
that's
arrive at.
kind of the consensus.
So long COVID technically might not have really anything. Well, it will have things to do with COVID, but it might not be.
I think it's going to present a deeper understanding of how the immune system, how viruses and human immune systems interact, and I think good will come of that.
Yeah. Oh, yeah.
Yeah, but I think it's going to be a long time before I can walk into an exam room and say, hey, I've got 5 practical things you should do.
Right.
I mean, right now I go in and I talk about lemon and clove. And
Yeah,
they just
drink
look
water, right?
Yeah, make sure you sleep. And they just look at me like, yeah.
Yeah, right. Yeah, thanks. I want the
Yeah.
machine that's going to make me better. Point the ray at me.
Right, exactly.
That's got to be frustrating as a healthcare provider.
It is.
Yeah.
But it's also super interesting that so many of our baseline best recommendations are the same thing.
Just across, right. Let's look. One thing
Exercise, sleep.
I've been struck again and again with our conversations for years now with this is how many things come down to inflammation.
Right.
So deal with inflammation and you deal with all of these other things.
Except
like
when inflammation's good.
you see,
Yeah.
And the way that symptoms or conditions can sort of snowball each other. Like I was thinking about this when you're going through the long COVID symptoms and you know, if you have something like losing a sense can kind of spiral into a sense of isolation in a way, and the brain doesn't deal well with that,
Right.
and we end up becoming worse off. You know, you lose one thing, and then it becomes, you know, you lose
Right.
some follow along, you know,
Right.
capability. It's just, it's almost
It's interesting how you can look back on a life in detail and look at what were at the time inconsequential events
right,
that turned
yeah.
out to be pivotal.
that reverse butterfly effect like that.
Yeah, totally.
Man.
Bizarre. But next time, there's a new hospice in town. I'm super curious about it. And so I was hoping to connect with them, and then maybe in the next week or two, we could have them come in and talk about what services they can offer Del Norte. Any new service in town medically is like super exciting.
Yeah.
So, and Lord knows we need it.
And with an aging population. And
With the downfall of resolution care, which is no longer really offering anything of consequence.
Really.
It'd be interesting to see what this hospice program can offer.
Okay. Well, I look forward to seeing what you can find out.
Yeah.
All right. That's it for this week's Health Matters. Thank you very much, Lynn. We'll talk next week.
We will. Thanks. Bye.